Okay, hello. My name is Arndt Vogel. I'm a hepatologist from Hanover in Germany, and I would like to talk today about the medical treatment of perihilar cholangiocarcinoma. So when we talk about biliary tract cancer, and specifically from the view of systemic therapy, in the past we have tended to lump all different subgroups of cholangiocarcinoma into biliary tract cancer. And we did not distinguish really between intrahepatic, perihilar, or distal cholangiocarcinoma. But we have realized today that this is most likely required for the best medical treatment. First of all, when we look back and look at the incidence of the different subtypes of cholangiocarcinoma, and I think this has been discussed before, we do see a rise of intrahepatic cholangiocarcinoma, which is most likely due to the risk factors we are increasingly recognizing in biliary tract cancer, such as viral hepatitis, but also metabolic diseases. And we see pretty stable incidence rates for the extrahepatic cholangiocarcinomas. And when we think about medical treatment, the preferred treatment and the best evidence-based treatment we have is chemotherapy. And the standard of care in first-line therapy is gemcitabine and cisplatin, which is based on the ABC02 study, which was published by Juan Vogel almost 10 years ago. And this standard has not changed over time, and we have seen here in the study a decent median overall survival increase compared to gemcitabine alone. Then for many, many years, there was not really a second-line treatment established. And again, it were the colleagues from us from the UK who established the standard of care in the second-line setting with the ABC06 study. And in this study, they looked at the efficacy of FOLFOX, again, a platinum-based chemotherapy in the second-line setting compared to placebo. And as you can see here, the median is not really very significantly improved, but overall, this is a positive trial. And with this, we have good phase 3 evidence to initiate second-line treatment in biliary tract cancer. Of course, there are other chemotherapies, combination triplets currently tested, but for none of them we have so far phase 3 evidence. When we look at in more detail at the different subgroups, so far we could not really distinguish different efficacy of chemotherapy in the intrahepatic cholangiocarcinomas versus the extrahepatic cholangiocarcinomas. So we definitely can use it in the perihilar cholangiocarcinoma. The question is, how can we improve systemic therapy in the future? And as we have learned also during this Congress, there are two different approaches. One is the targeted therapies, and I think this is a very exciting time for biliary tract cancer, and the other one is immunotherapy. And I want to show you some data. Targeted therapies have already been recommended in the ESMO guideline in 2013, published by Juan Vogel. And we have now more and more evidence based on the next generation sequencing studies that have been published in recent years that we do have different genetic alterations in extrahepatic, intrahepatic, and also gallbladder cancer. And very excitingly, many of these genetic alterations are druggable, which means we have already today drugs and drug combinations which are specifically targeting the pathways that are activated by these genetic alterations. And interestingly, here we need to distinguish a little bit more closely because some of these alterations can only be found in intrahepatic cholangiocarcinomas, and others are found more often in extrahepatic cholangiocarcinoma. And it's interesting to see that not only with the distinction extrahepatic and intrahepatic leads to different genetic alteration, also when we look at the same underlying liver disease, which is highly associated with biliary tract cancer, primary sclerosing cholangitis, we can see that these underlying liver disease induces different subtypes of biliary tract cancer, both intrahepatic but also extrahepatic and perihilar cholangiocarcinoma. And as you can see here in this analysis, which we have published last year, you can see that there are different genetic alterations depending on whether the tumor arises in the intrahepatic compartment or in the extrahepatic compartment. And for example, KRAS mutations are more often in the extrahepatic cholangiocarcinoma. And one interesting observation from this paper was also that there are indeed a couple of druggable genetic alterations also found in this PSC-induced biliary tract cancer, and one of them, which is more frequently found in the also extrahepatic cholangiocarcinoma, are the HER2 alterations. And I want to give you two examples on genetic alterations where we already have very interesting data for targeted therapies. One of them are the FGFR2 fusions, which are primarily found in the intrahepatic cholangiocarcinomas. Now we have seen phase 2 data from with many different drugs, which are currently tested also in phase 3 setting. And these trials have very consistently shown that with the FGFR inhibitors, we can achieve a very high disease control rate in FGFR2 fusion-driven cholangiocarcinomas. And pemigatinib was the first drug which received approval by the FDA in the second-line setting for patients with FGFR2 fusion-positive carcinomas. But these fusions are mainly found in intrahepatic cholangiocarcinoma. But I have mentioned before, not only in the PSC-induced cholangiocarcinoma, but also in the extrahepatic cholangiocarcinomas without PSC, we can find HER2 alterations, not only amplifications, but also mutations. And HER2 is a very interesting target. It's mainly used in breast cancer, for example, but we can also find HER2 amplifications in a couple of GI cancers, and among them, the biliary tract cancer. And some data that have been published for targeted therapies are for the drugs pertuzumab and trastuzumab, which both bind to the receptor and which leads to an inhibition of this signaling pathway. And as you can see on the right-hand side, the numbers are very small, but I think the data are really interesting. And it appears that also in biliary tract cancer, we can achieve a disease control with these targeted approach against the HER2 receptor in patients, not only with HER2 amplification, but maybe also with HER2 mutations. And the other approach, which I have mentioned before, is immunotherapy. And unfortunately, here we are not that far as with the targeted therapies. So outside of clinical trials, I would not recommend immunotherapy in our patients. The best data we have so far seen for immunotherapy are coming from Korea, from the MEDITREME study, gemcitabine cisplatin in combination with the dual checkpoint inhibition. Here, the disease control and the response rate looks very promising. And among them, there were also a couple of extrahepatic cholangiocarcinoma, indicating that we might be able to increase the efficacy of chemotherapy with the addition of immunotherapy. But this, of course, needs to be proven in a phase 3 setting and also in a non-Asian Caucasian population. With this, I would like to end, and my take-home message here would be for perihilar cholangiocarcinoma, chemotherapy, the standard of care in the first line and second line setting. Immunotherapy we cannot recommend at this point in time for as a treatment in perihilar and cholangiocarcinoma at all outside of clinical trials. And the more exciting part in cholangiocarcinoma are definitely the genetic alterations. So I definitely recommend molecular profiling of all tumors in our patients. In almost half of the tumors, to be optimistic, we can find today already druggable alterations. I have mentioned two of them, FGFR2 and HER2. There are more IDH1 mutations, also primarily found in intrahepatic cholangiocarcinoma, BRAF and NTRK alteration. Here, I think it's really critically important, the timely diagnostic. You need to know your panel to analyze your genetic alteration. And I think here the treatment planning really needs to be done very carefully to not miss an opportunity for our patients. And we also need to acknowledge that we do not have very good phase 3 evidence for many of these genetic alterations. Therefore, a discussion in the multidisciplinary molecular tumor board is highly recommended. With this, I would like to end. These are my contact data. If you have any questions, and I'm now looking forward to our panel discussion. Thank you very much.